Over the past few months, I've answered thousands of TikTok live questions on muscles and joints. The issue tends to be, though, it's quite a short answer, around a minute. So I'm going to take some time to go through 3 cases in a bit more detail. So we're going to have one on rib pain, one on hip pain, and there's one then on frozen shoulder. Now, if you'd like me to go through your particular case, there will be a form in the description below. Let's get into the first question. I've had pain radiating inside my armpit and to the left breast that spread to the left rib and along the left hand. It even goes to the back on the left hand side. My rib hurts when I touch it, and I've had a breast, armpit, abdominal ultrasound, all clear. So how do we reframe that, make it super short? In essence, what we have is on the left hand side, we have armpit, rib, as well as radiating pain into the back, into the hand. So we've got a few things going on. Now, with all things, we usually start with, well, let's make sure it's nothing too nasty. So before we look at muscles and joints, we look at stuff which don't revolve around me. Anything to do with heart and lungs, blood vessels, the nerves, not something to do with the muscle and joint, we rule those out first. Now, there are broad ones we always look for, but specifically in this case, the ones that we'd have to double check are anything with the breast has its own red flags and risk factors. Anything to do with chest pain or ribs, you have to rule out something to do with the lungs and the heart. And if you have pain which is radiating, meaning it goes from one place to the other, in this situation we had radiating into the left hand, you have to consider the nerves. Now when it comes to the breasts, you look at, is there any skin texture changes or color changes? Any issues with nipple discharge, as well as any clear sort of masses or lumps that shouldn't be there. When it comes to heart and lungs, it's all about, is there pain when we exert ourselves, breathlessness, pain into the jaw, into the back, those heart symptoms, and any history of respiratory infections. Nerve-wise, now nerves, if they go wrong, they give you sort of that tingling feeling that you do when you sleep on your hand incorrectly during your sleep. So you get that tingling feeling, you may have weakness, numbness, coordination issues, so we're always on the lookout for all those possibilities of something nasty. Now, once those have been ruled out, we're now back into the world where I live. Musculoskeletal, muscles, joints. And the first place we always start is local versus systemic. We want to know, we have all this stuff on the left-hand side. However, is it only the left-hand side, or is that actually one part of a smaller, or no, one small part of a bigger puzzle? What that means is we're going to have to look at the type of pain we have, where we have it, and any other symptoms to see actually, is this a broader picture rather than just something in the left-hand side? However, in this case, the distribution, so where it is all on the left-hand side. We don't have the right hip, the right knee, the right shoulder. It's all on the left-hand side. So it's looking like it's a lot of local issues. We also don't have any systemic symptoms. We don't have rashes or fevers or fatigue. The pattern, it seems to all be in that left-hand side. It doesn't seem to be widespread or diffuse. And finally, no sort of stiffness that's prolonged like we get in inflammatory conditions. So overall, it does look like whatever's going on, whatever's causing the pain, is somewhere in that left-hand side. This isn't something systemic. Once we have that narrowed down, where do we begin? Well, we start hunting for clues, and that really begins with just simply looking. We're going to observe what actually is there in that area that may give us a couple of clues as to what's going on. And what really are we looking for? Any clues as to exactly the location where, all right, I can really see there's something right in this area. Maybe that will tell us something. Or something that tells us the actual underlying condition. Is it inflammatory? Is it vascular? Is there bruising? All those sort of things. So specifically in this case, we're looking for any swelling. We're looking for any discoloration. Has it gone paler, blue, red? We're looking for muscle wasting. If we look left to right in the front, side and back of the shoulder, can we see that the muscles might have gotten smaller? Is there clearly any change in the posture? Either that might show that the nerves have gone wrong, or it's just something of how we move. So we're really looking for changes left and right, the color, muscle bulk, so is there any atrophy, as well as some clear deformities to either the posture or the rib cage itself. Once we've had a good look, the thought that comes to mind is, well, what actually is in that area? If we have pain somewhere, there has to be something causing that local pain. And that really boils down to anatomy. Now, we won't go through all the anatomy because we'd be here all night, but broadly you have the ribs, the shoulders, the neck, the upper back. That's the area we're looking at. And in all that area, we do have the bones. We have the bones of the spine, we have the bones of the ribs, and the bones of the shoulder joint. And all of those bones attach to each other, so we have joints, they all have muscles, and we have a whole bunch of nerves in the area. So it could be a bone, could be a joint, could be a muscle, could be a nerve. We have all those things that we have to consider. Now, how do you ever consider, well, what exactly is it? How do you narrow that down? And the way you do it is you poke and prod the body to see what makes it worse. If something is angry, what you want to do is try and make it angrier. Or you can make it better. Most of the time we try and make it more angry because that really tells us something. Now, what do we do in order to do that? We usually start by poking and prodding, what is professionally called palpation. And we're going to poke and prod all the muscles. So we're going to poke the pecs in the front, the lats in the back. We're going to poke in between the ribs, the intercostal muscles. We're going to make sure to see if this is coming from a muscle. If we poke into it, it'll give us some pain. We're also going to poke the joints. One particular one, anything with a rib pain, is the joint in the front between the breastplate and the rib itself. So there's a condition called costochondritis, which is inflammation of the little cartilage in between the rib and the breastplate. We're going to really press in there. Does that hurt? Along with that, we also want to poke in between the collarbone and the back neck muscles, in that little gap, because that's where all the nerves from the neck leaving towards the arm and the shoulder are all gathered in there. And if they're irritated, if we press in that area, they're really not going to like it. So a lot of poking and prodding, trying to make the pain worse. Along with poking and prodding, we're going to move things. If an anatomy or anything is angry at you, if you move it, either stretch it, or if it's a muscle, contract it, it will hate you. So that's what we're trying to do. Again, we're going to move the neck and the shoulder and the upper back, but also we're going to move the nerves. So we'll just move them broadly. So for the neck, it's forwards, backwards, side to side. Same for the shoulder, same for the upper back, moving it in all directions. What does that do? Along with that broad movement, we're going to do some special tests. So for the neck, we're going to have a look at, is there a pinched nerve in the neck? We do what's called Sperling's test, where you bring the head back, twist it towards the side which we have the issue, in this case the left-hand side, and we're just going to hold that position for a couple of minutes. If it's pinched, it'll make it worse. We then reverse that and put our hand on the top of our head, a relief position. If it is a pinched nerve, that should make it a little bit better. Another place the nerves can be pinched is that area just on top of the collarbone, right on the side of the neck, a thoracic outlet. And one test for it is called the Roux test. What you do, you go in this surrender position, so you're in 90 degrees, and you just open and close your hands for 3 minutes. And if that makes it worse, it can be a sign of your nerves being pinched just around the collarbone, and that's then giving you the symptoms locally, as well as then into the arm. For the shoulder, we don't really have any evidence that this is actually like a rotator cuff or a labrum, something in the shoulder. So do we need specific tests? It doesn't look like it to me. Now, perhaps if we poked and prodded and seemed like, oh, actually this could be a shoulder, then we would. But with the question at hand, it doesn't seem like we do. Finally, we have ribs, so we should do some breathing. What does breathing do? Does that make it worse? Does it do nothing? That can be an important thing. Now, a few special considerations to have is, because we have breast pain, we want to know, does it get worse or better with the menstrual cycle? Where again, that will localize it to the breast. Because it's the ribs, we're thinking breathing. So do we have anxiety? Do we have any stress? What does that impact on the rib pain? If it's a pinched nerve in the neck, we're thinking posture, we're thinking sleep. What do we know about that area? And because it's the shoulder, we do think a lot about upper back shoulder posture and also use. Do we just use that area a lot? Are we left-handed? Do we do a lot of work with that left hand? Those are all things that we really should consider. With that all taken into hand, what are kind of the most likely diagnosis without having done any of that poking or prodding or movement just from the question alone. We have thoracic outlet, which is where the nerves get pinched just above your collarbone here in the side of your neck. We also have radiculopathies, where the nerve gets pinched actually in the spine, either the neck or upper back. We have an issue with the nerves that go along the ribs called intercostal neuralgia. It could be something to do with just the muscles, so myofascial pain syndrome. It could be the pecs, the lats, serratus anterior, any of the rotator cuff muscle bellies in the back. So it could be many muscles. Then the last one there, costochondritis, and that is the pain I talked about before, which hurts right in the front of the chest when you press in the ribs. Now, with all that considered, what is the next step? We're really still in the diagnostic stage, so we have to perform all those provocative movements. We have to poke it, we have to move it. We're all about trying to find out what makes it worse so we can narrow down what the likely causes are. At the same time as trying to find it, there are actually a few things that we might be able to do. And they're all really things which are always beneficial. Improving breathing, diaphragmatic breathing. Improving posture and upper back mobility, never a bad thing. And finally, shoulder blade exercises. Anything to do with the shoulder or neck, you always start really with shoulder blade exercises because it plays such a key role. And finally, you just want to monitor any new symptoms or any changes in the symptoms. Because we're working in the ribs, we're working in the breast area, we always have to keep an eye out just to make sure nothing shifts or changes. And that concludes that first little case. On to question number 2. I've been getting this deep ache on the outside of my left hip. It gets worse when I sleep on that side and sometimes when walking. It's been going on for a few weeks and stretching does nothing. How would we summarize that? It's lateral hip pain aggravated by loading. In essence, we've got pain on the side of the hip, which if we put stress through it, it hurts more. As usual, first thing, any red flags. We want to make sure it's no infection, no cancer, no bone fractures. And in this case, we got a few specific areas we have to look out for. The first one is the bone. Any bone cancers, any bone fractures. So if it's pain at night, which we do have, but we want to make sure that it's relieved by rest. If it's just constantly going and it's pain at night, something to look out for. Any history of bone osteoporosis, and also that if the pain has gotten worse really quickly. So it didn't come on gradually like a wear and tear, it just came on like a flash. Along with that, we're always looking out for anything to do with the nerve. Any tingling, any weakness, any pain below the knee as well. Because if it's a hip pain, well, it should be around the hip or the thigh. If it goes into the calf, into the feet, then we're more thinking it might be a lower back issue where the nerves are being pinched. Finally, inflammation. If we're seeing it's on both sides of the hip, could be inflammatory. It isn't in this situation. Any morning stiffness that lasts a long time, over 30 minutes, again, we think it could be something inflammatory, as well as any sort of family history or personal history of an autoimmune condition. But we don't have any of those in this situation, but always something to keep an eye out for. Once we've ruled out the nasties, we're back into the world of, is it a muscle or a joint? That sort of thing. And we always start, as before, is it something local within the hip in that area, or is actually that just a piece of a bigger puzzle? Is it systemic? Now, what we're looking for is, where is the pain? So in this situation, it's only on the left hip. It's not in that knee, it's not in the other hip, it's not in the shoulder, so that seems like it's local. We also don't have any other systemic symptoms, a fever or a fatigue, and it does get worse with pressing on it, like when we're sleeping, and also walking. So it all looks like it's quite local to that left hip. Nothing to think, okay, this actually might be something inflammatory or systemic. All looks like this is just left hip pain. Now, where do we begin? We have a look. What can we see? Are there any clues that might lead us down the path as to what actually is the issue? Now, what are we going to specifically look for? Now, it is the hip, and what does the hip do a lot of? Anything to do with walking or standing, so gait or posture. We're going to see, as we walk, do we see a lot of hip and pelvic shifting side to side, what we call the Trendelenburg gait. So if you're dropping the hip down, it can be a sign of hip weakness. We're also looking for, actually, is the pelvis itself slightly slanted to one side? Is one leg longer than the other? And is the muscle bulk, so how big the muscles are Are they different left to right? Anything that might give us a hint as to what's going on here. We're also looking for any bruising, any swelling that might show us actually what's going on underneath the skin. Once we've had a look, we can then start to think, in that area, what do we actually have? And we have quite a few things. We can categorize them into, we have the lower back, we have the pelvis, we have the hip, we have the thigh. Now each of those areas, we have a bone, we have joints, we have muscles, and we have the nerves. Now along with that, in the hip we also have bursas, and bursas are little pads that sit under muscles and tendons to prevent friction. And we also have what's called the iliotibial band that runs from the top of the hip down the side of the leg to the knee and really aids in controlling how the whole leg works. So we have a whole bunch of things it could be. So how do we narrow it down? As with the previous case, one makes it worse. So it's too many possibilities to consider. So we just have to see if we poke and prod and move things, what gives us a sign that that looks like that is what's making the issue. We try and make it worse. We start with palpation. We're going to poke and prod our way around the hip to see if we can bring it on. We're going to definitely poke on the side of that hip where the issue actually is, poking both right on the bone on the outside. You'll have your little hip dip area. We're going to poke all around the back to where those muscles are. We're going to poke a little bit down the thighs into the muscle, right in the back to the pelvis, because it could come from the pelvis. So the joint where the pelvis meets the spine, called the SI joint, sacroiliac joint, as well as then a little bit up into the lower back and into the muscles. So we're going to poke all around the hip, trying to reproduce some pain. And when we look at reproducing the pain, we're not trying to just make it hurt, we're really trying to have the same sensation as the complaint. Because if you poke into any muscle hard enough, it will hurt. Along with that palpation, we want to move loads of things. We want to move the lower back, the hip, the pelvis, as well as actually trying to contract some of the muscles around the area. So usually we'd start with move the lower back forwards, backwards, side to side and twisting it. Same with the hip, forwards, backwards, across the body, away from the body, twist it in and out. When it comes to the pelvis, usually what we're trying to do is have one leg forwards, one leg back, just to try and strain that pelvis a little bit. We also try and just press on it from the back, press on it from the front, trying to get some stress through it. When it comes to the actual side of the hip where the muscles are, the main thing we would do is actually try and resist. So we're trying to push the leg out to the side, but have some sort of force that's going to stop us. So the muscles that bring the leg outwards are going to be working, and if they're not happy, then they will just shout that little bit more. So we're going to do a resisted hip abduction. Other special tests for the lower back, we want to see, is it a pinched nerve? So we do what's called the slumps test. We tuck the chin in, round our lower back, straighten the leg, and then bring our toes towards the shins. If the nerve is pinched, it really won't like that. Within the hip, we're really just putting the hip in some particular positions. We put it in like a figure 4 position called the Faber's test, and then we just bring the knee towards the opposite shoulder, what we call the Feder's test. So we're really putting some stress through the hip. Some other special considerations that we have to think of, because it's the side of the hip, menopause status. If it is a muscle tendon, then people in menopause are more prone to have tendons degenerate. So that's one thing we have to keep in mind. Training load is another one. Because it's the hip and it's a lot of walking, have we had a recent change in how much we walk or started running? Something we have to think of. Sleeping position. Do we have our legs really close together, which is going to put some strain on the hip if we're a side sleeper? And just, is there a lot of pressure happening on that hip as we lie on it? Finally, anything that just is going to change how our lower leg works, obesity, pelvic alignment, foot biomechanics, and just how we walk. Anything that alters how much force goes through the hip is something we have to think of, because that might actually be a root cause. With all that being said, what is the most likely diagnosis in this situation? The top one has to be something to do with the glute tendons, a gluteal tendinopathy / bursitis. Now, most of the time, if you have inflammation of a bursa, it comes secondary to a tendon issue. So gluteal tendinopathy. Second, hip osteoarthritis. If you have wear and tear, it's going to hurt deep in the hip. You should have some stiffness, which wasn't in the question, so that'll be something to look out for there. Third, iliotibial band syndrome. That does tend to hurt like on the side of the hip in that area, particularly with walking. So we'd really be trying to stress that ITB. Usually you do that with what's called Auber's. You bring the leg backwards and behind the other leg, really trying to stretch the outside of the leg. Number 4, lumbar radiculopathy. Has the nerve been pinched in the lower back? And that's actually what's causing us to tribble. And finally, a femoral stress fracture. It's not super likely in this situation, but always something to keep in mind, anything to do with the side of the hip. What's the next step? What do we want to do? Well, we're still in the diagnostic phase, so we want to poke and prod, and we want to move, really narrow down what the possibilities could be so that we have a really good idea as to actually what's going on. Along with that, even though we might not know the diagnosis yet, as with the other one, there's always things we can start because they just will do a lot of good and they're very low risk. So we can start strengthening that gluteus medius, things like clamshells, really focusing on our gait, particularly anything to do with the knee rotating in, doesn't like that, the hip. And also, if we're in bed, putting a cushion between the knees just to prevent that hip rolling forwards. And as always, we're just keeping an eye on it. We're making sure there's no new symptoms, they don't change and get worse or shift around. And if there is no change within 3 months, despite starting to do some exercises, stretches, and activity modifications, then that's a sign that perhaps we need to take a different path. And that summarizes that particular case. Right, let's move on to the third question, last one. I've been told I have frozen shoulder. What can I actually do about it? It just keeps hurting no matter what I try. So let's first translate it into what would we answer in a medical type question, which is really what are the management options for the freezing, the painful phase of frozen shoulder. This individual, it's still hurting, meaning that it is the freezing phase of frozen shoulder. The first thing you really want to know is, well, what actually is a frozen shoulder? What a frozen shoulder is when we have inflammation within the shoulder capsule, and that is really the soft tissue which holds the shoulder joint together. When that becomes inflamed, if it's prolonged for a long period of time, it starts to get all fibrotic and stiff, giving us a frozen shoulder. It can last anywhere from like 1 to 3 years. Usually it starts for a few months being painful, then it slowly freezes. That freezing phase itself can last a year, and then it slowly starts to sort of thaw. It starts to improve. And that's where we get the 3 phases. We have the painful inflammatory phase, the freezing. We then have the stiff frozen phase, and then the thawing phase when it starts to move. Now, why does it actually happen? I touched on it a little bit before. It starts usually, something triggers it in the shoulder. The shoulder is triggered and something angers it and it becomes inflamed. That inflammation becomes prolonged for some particular reason, and that prolonged inflammation leads to all the soft tissue becoming a little bit fibrotic and stiff, giving us the frozen shoulder. Usually it gets worse in terms of turning the shoulder outwards. That's the first one to go, but over time, almost all range of motion in the shoulder begins. One important note is anything that either increases the likelihood of things becoming inflamed or increases the likelihood of things becoming stiff are risk factors for frozen shoulder. So diabetes, thyroid, injuries, autoimmune conditions, they're all likely to increase how inflamed something becomes, or simply the likelihood that it even begins to become inflamed. So they're all risk factors. Menopause has a big link to the quality of soft tissue, and therefore it can increase just the likelihood that it goes stiff in the first place. So that's where menopause is also a risk factor for frozen shoulder. The typical presentation in terms of how does it look, it usually starts with a deep pain in the shoulder. That's that inflammatory component, usually worse at night, and inflammation pain tends to be worse at night. At night, the anti-inflammatory hormone cortisol is at its lowest, and so anything that's inflammatory will just hurt more at night. Then it gets into the stiffness, especially turning it out, external rotation, and it just gradually gets worse and worse. One thing to mention with frozen shoulder is, with all things, you want to make sure that it couldn't be something else. So what things would we end up considering? Firstly, it is the shoulder. So anything within the shoulder, we also want to make sure. So it could be a rotator cuff, osteoarthritis, could be a pinched nerve in the neck, and something called Parsonage-Turner syndrome, also called brachial neuritis, where all the nerves that leave the neck, the brachial plexus, get inflamed and do cause you severe pain in that area and a lot of weakness. Now, any of those, they do have their own particular categories, which really points them out as to whether it is or isn't the condition. But it's always things that we look at. Other things, red flags. Is it something nasty? Is it a Pancoast tumor, which is a tumor on the top of the lung? Or is it an infection? We're always keeping an eye out for that. Not very common, but yeah, you can't really miss it. You don't want to, at least. And then finally, any of the risk factors. Now, there isn't any evidence that actually treating the risk factor treats the frozen shoulder, but surely it would help at some point. So if you have diabetes, a thyroid, an autoimmune condition, it wouldn't be a bad thing to see, is there something I can do to improve that? Now, if you have a frozen shoulder, do you need to get it referred? Do you need to get a scan or an image done? The usual answer is no. Usually, if you've been diagnosed with frozen shoulder, you don't need an MRI or an X-ray. The only times you do is when it looks like it isn't a frozen shoulder. So if it looks like, hang on, this really doesn't fit the frozen shoulder, then perhaps you need to get it re-diagnosed. Otherwise, it tends to be, can be up to 3 years. We can be a little bit patient with it, and you don't tend to have any sort of scans. Now, the real question is, well, if you have a frozen shoulder, particularly in that freezing phase, what do you actually do? And the whole thing we're trying to do is prevent the inflammation worsening, because that's the key part of that first phase of the frozen shoulder. We don't want that inflammation to get worse, and we want to really try and preserve as much muscle strength and mobility as we can without provoking the shoulder. How do we do that? We have 3 categories: pain relief, activity modification, and just straight up mobility. When it comes to trying to do pain relief, this is inflammatory pain. So things like ibuprofen may be helpful, things like ice may be helpful, as well as corticosteroids. Again, I'll mention again the risk factors: diabetes, thyroid, autoimmune. Perhaps targeting those may be helpful as well. In terms of not making it worse, we're all about protecting the shoulder. Anything overhead, it won't like. Anything with a lot of twisting or heavy lifting, it won't like. And we don't want to stretch it just yet. The shoulder is inflamed. Stretching puts stress on it, which we want to avoid. Now, what we do want to try and mobilize and stretch are, the other things. So we do want to keep the shoulder gently moving. So we do pendulum swings. We do want the upper back and neck to be nice and mobile to make sure they're not contributing to the shoulder. And we actually want to start doing some exercises. So if you can do shoulder blade exercises in that painful phase, that hopefully will put you in a better position long term. And that is a brief little summary of frozen shoulder. If you've enjoyed these cases and would like me to review yours, the form is below in the description. Thank you.